My name is Dr. Brian Quinn, and I've worked as a pathologist at Baptist Health since 1995. I am board certified in anatomic pathology, clinical pathology, and transfusion medicine, and a medical director of the blood bank at Baptist Little Rock. I've also been actively involved in the blood management program here at Baptist. Earlier this year, Baptist Health Physician Partners established a multidisciplinary committee to oversee a system-wide blood utilization quality project, and we hope that this project will contribute to improved care and better outcomes for the patients that we serve. As part of this project, I have put together a series of presentations that are intended to update clinicians regarding the benefits of a conservative approach to blood transfusion. The current presentation, which will last approximately 15 minutes, is intended to give an overview of patient-centered blood management, and I hope that the information shared will serve as a background for the other recorded presentations that I have put together regarding conservative blood transfusion strategies. Each year, approximately 15 million red blood cell units are transfused in the U.S., and another 6.5 million other blood components are also transfused. Transfusion occurs in greater than 10% of all hospital stays that include a procedure. Although blood transfusions may be life-saving, it is also important to recognize that there are many associated risks. Blood management is defined most succinctly as an evidence-based, multidisciplinary process designed to promote the optimal use of blood components. The goal of blood management is to ensure the safe and efficient use of the many resources involved in the complex process of blood component therapy. Institutional experience and national databases suggest that a restrictive approach to blood transfusion is being increasingly implemented as best practice because of an array of benefits, including improved patient outcomes and an overall reduction in costs. There are multiple components that make up a blood management program, such as evidence-based and peer-reviewed blood transfusion practice guidelines, screening for anemia and management of anemia in medical and surgical patients, including the use of pharmacological interventions to optimize red cell mass, intraoperative blood conservation measures such as minimally invasive surgery and cell salvage techniques, and the avoidance of unnecessary diagnostic testing to minimize iatrogenic blood loss. One of the driving forces behind the blood management movement has been the increasing body of scientific evidence that has shown that transfusions are less beneficial and linked to more adverse outcomes than previously recognized. In addition, there have been a number of studies showing that the risks associated with not transfusing are not as great as many physicians assume. Data from multiple randomized controlled trials have demonstrated that conservative transfusion practices are equivalent or better than liberal practices and well tolerated, even in a number of high-risk groups, such as the elderly and ICU patients. This kind of evidence prompted the National Summit on Overuse, which was convened by the AMA and the Joint Commission in 2012 to cite red cell transfusions as one of 5 clinical practices that is overutilized. The working group at this meeting acknowledged that there are gaps in medical school and professional education regarding transfusion medicine, commenting that many excellent trials and guidelines are available that are not being followed. At the federal level, the Health and Human Services Advisory Committee on Blood Safety and Availability issued several statements and a letter to the Assistant Secretary of Health in 2011, recognizing the impact that transfusion practices have with respect to quality and cost, stating that blood transfusions carry significant risks that may outweigh benefits, and commenting that the wide variability in the use of transfusions suggests both excessive and inappropriate use. So the transfusion of blood is not a benign process, with multiple studies demonstrating that blood transfusions are an independent risk factor for a number of adverse patient outcomes, such as increased mortality, increased infection rates, including postoperative wound infections and nosocomial infections, such as vascular line-associated infections and pneumonia, multi-organ dysfunction, predisposition to cancer recurrence, prolonged ventilatory support times, and increased ICU and hospital length of stay. Although the deleterious effects of blood transfusion are evident, a specific etiology for many of these negative side effects has not been definitively established. Nevertheless, several mechanisms have been proposed for these harmful effects of transfusion. Some of these may be related to the introduction of foreign white blood cells, cytokines, and other leukocyte-derived biological response modifiers released from deteriorating white cells, as well as soluble HLA peptides that circulate in allogeneic plasma and that collectively lead to a reduction in T-cell mediated immunity and natural killer cell activity. Unfortunately, these detrimental immune system alterations often occur in patients who are already stressed by surgery or illness. In addition, red blood cells may be stored for up to 42 days prior to being transfused, and erythrocyte damage related to the duration of storage, also known as the storage lesion, is hypothesized by many scientists to partly account for these observed adverse patient outcomes by causing harmful microcirculatory effects in the recipient. Stored red blood cells, especially those greater than 15 to 20 days old, are more rigid and relatively depleted of nitric oxide, and these alterations in the transfused red cells can impede blood flow to the viscera through vascular obstruction and or vasoconstriction. Stored red cells also have a tendency to hemolyze in vivo, releasing vasoconstrictive substances such as cell-free hemoglobin. Prolonged storage of red cells is also associated with the progressive accumulation of harmful inflammatory mediators and cellular debris related to ongoing cell death, and may also impair the ability of transfused red cells to release oxygen at the cellular level. An American College of Surgeons National Quality Improvement Program study that was published in 2009 provides data demonstrating the negative impact that blood transfusions may have. This study searched for patients undergoing major surgical procedures in 121 hospitals using the National Surgical Quality Improvement Program database of general surgical outcomes. The cohorts evaluated in this study were patients who received either 1 unit or 2 units of red cells, and these were compared to those patients who were not transfused at all. By restricting the cohorts to those who received 2 or fewer units of red cells, the authors looked at low-volume transfusions and eliminated patients with serious disease, including massive bleeders. After adjusting for multiple underlying clinical factors, including transfusion propensity, procedure type, wound class, operative duration, and numerous other patient risk factors, the authors showed that the intraoperative transfusion of just 1 unit of red cells significantly increased the risk of 30-day mortality, composite morbidity, pneumonia, and sepsis in these general surgical patients. Furthermore, the transfusion of 2 units additionally increased the risks of these adverse outcomes, as well as the risk of surgical site infections. The authors concluded that the intraoperative transfusion of red cells increases the risk for mortality and several morbidities in general surgery patients. These risks, substantial for even 1 unit, remain after adjustment for transfusion propensity and numerous risk factors in the ACS National Surgical Quality Improvement Program. Another example of a study that evaluated outcomes of patients who were not transfused compared with patients who were transfused red cells is briefly outlined on the next slide here. This study was carried out at the Cleveland Clinic and published in 2012. The authors evaluated Jehovah's Witnesses who refused transfusion and underwent cardiac surgery, predominantly consisting of coronary artery bypass surgery, and they compared morbidity and mortality in the Jehovah's Witnesses with a group of non-witness patients who received 1 or more transfusions and were matched by propensity comparison methods. And so the witnesses provided a unique natural experiment in blood conservation. The primary outcome measures in this observational study that spanned almost 20 years were postoperative complications, in-hospital mortality, and long-term survival. In this study, the authors found that witnesses had significantly fewer acute complications, such as MI, additional reoperation for bleeding, and less prolonged ventilatory support times. Witnesses also had significantly shorter ICU and hospital lengths of stay, and they had better one-year survival. There was a similar overall risk of in-hospital mortality and 20-year survival. The authors concluded that witnesses do not appear to be at increased risk for surgical complications or long-term mortality when comparisons are made by transfusion status. Thus, current extreme blood management strategies do not appear to place patients at heightened risk for reduced long-term survival. Of course, an important limitation of this observational study is the fact that witnesses who undergo cardiac surgery may be a healthier group of patients because those witnesses who are believed by their surgeons to require transfusion in order to survive cardiac surgery may never go to the OR at all. However, in a commentary that accompanied the publication, a cardiothoracic surgeon from the University of Kentucky remarked that the Cleveland Clinic findings add to previous research that a more conservative use of blood transfusion is in the best interest of most patients. Against this background of data showing that patients who are transfused are placed at an increased risk of adverse clinical outcomes are a number of randomized controlled trials providing data documenting the relative safety of lower hemoglobin levels in both high-risk and low-risk patients, and several of these clinical trials are discussed in more detail in a separate presentation that I have put together entitled Studies Evaluating Hemoglobin Thresholds for Blood Transfusion. So the primary goals of blood management programs are to enhance patient safety and improve patient outcomes. Blood management can also generate financial savings by decreasing costs to the patient and to the global healthcare system. There are numerous costs associated with blood transfusion, starting with our purchase of the blood product from the American Red Cross. For example, each unit of red cells costs over $200, while a single apheresis platelet product is $500. In addition to the acquisition cost, there are multiple direct and indirect costs associated with blood transfusions, such as costs incurred for lab testing and processing, including considerable blood bank technologist time to work up patients with positive antibody screens, as well as supplies to administer the blood. There is also a significant investment of nursing time, beginning with obtaining the informed consent to careful monitoring of the patient during the transfusion. This does not include costs associated with the known hazards of transfusion that were previously discussed, such as additional time in the ICU and the cost of treating infections. It is also, of course, relevant to consider the advantage of such practices in the context of preserving a limited blood supply for those patients for whom the benefit of transfusion outweighs the risk. The other potential threat to a safe and readily available blood supply is the aging population, which is predicted to result in more recipients and fewer donors, putting further pressure on the blood supply to meet the demands. Thus, blood conservation provides a rare opportunity to improve patient care while reducing costs. So to summarize, this presentation serves as the background for additional presentations on the topic of adopting a conservative approach to blood transfusion. Additional topics that will be discussed in the other recorded presentations include a brief summary of the scientific evidence from randomized controlled trials evaluating hemoglobin thresholds for red cell transfusion, an assessment of the estimated risks of a number of transfusion-associated hazards, and an overview of Baptist Health's red cell transfusion guidelines.